This conference will now be recorded.
Hi, everybody. We are going to be talking about diabetic emergencies, syncopal episodes, strokes, and altered mental status, as well as seizures in this lecture. So we're combining a couple of chapters because they are kind of focusing on the same pathophysiology and the same disease processes. So first, we're going to talk about the pathophysiology of altered mental status and what it really takes in order for us to be conscious human beings. So our reticular activating system, this is in charge of whether it keeps us awake or whether it is time to sleep. So it's a series of neurological circuits in the brain that control the function of either staying awake, paying attention, or sleeping. What we need in order for our brain to survive is really only three things. We need oxygen, we need sugar, and we need water. So when we're looking at somebody who's suffering from altered mental status, generally it's one of these three things that's interrupted, and as a result, that's where we're seeing that altered mental status. So this is a diagram of what the reticular activating system looks like, where we have stimuli inside the neurological part of the brain. And as a result, it is either keying us to stay awake, pay attention, or when it's that time to actually go to sleep. So our assessment of that altered mental status, always seeing safety, especially when you are called to anybody with a dispatch information of altered mental status, because these individuals are acting outside of their norm. So for society, it's important that we stay safe, we don't harm others. But when somebody's suffering from that altered mental status, a lot of those culture cues and different components kind of get thrown out the window. Perform a primary assessment when we are doing this. Make sure that you're kind of in a good safe zone. You got a exit strategy plan, and you're far enough away from that patient that in the event that they do get violent, you can go ahead and retreat from them. Assess their ABCs, and then assess their mental status. So ask some of those key indicators as far as, are they alert and oriented? So do they know what day of the week it is? Do they know what month it is? Do they know some general information that the norm would know, like who the president is, what season it is, where are you right now? Then dive into your secondary assessment. So, we touched on respiratory and cardiovascular emergencies with our secondary assessment. And what these assessments are doing is basically playing a detective role as far as why is this individual at that certain state in their mind. So use your differential diagnosis and your body system exams. What differential diagnosis is eliminating certain characteristics or signs in order to start to pigeonhole yourself down the right category. So an example of altered mental status could be from a diabetic related emergency. So if I check a blood sugar and it is within normal limits, then I can kind of check that off the box. Then I can start going down different assessment tools utilizing that differential diagnosis. So first we're going to touch on diabetes. So diabetics, pathophysiology, we need glucose in order to create energy and function properly. So glucose, this is a form of sugar. This is that basic body source of energy. So in order to utilize glucose, we also need insulin. So insulin is a hormone produced by the pancreas. It can also be taken as a medication, and this is where our diabetic patients are going to come into play, because diabetics oftentimes don't have the means to create that insulin from the pancreas. So the definition of diabetes, this is going to be a condition brought about by decreased insulin production or the inability of the body cells to use that insulin properly. Two different types of diabetics, and then there is also gestational diabetes too. But type 1 diabetics, they generally don't produce any insulin at all. And that's where they're going to actually have to take some type of insulin in order for those glucose that we can see pictured to actually enter the cells. So insulin basically kind of is our transport regulator inside those cells. Type 2 diabetics, they do have insulin or some type of insulin production, but sometimes they don't have enough or they don't regulate that very well. So diabetic emergencies, we're looking at most oftentimes when we're called to the scene is for somebody who's suffering from hypoglycemia or low blood sugar. A couple of causes that we can see, maybe somebody took too much insulin. They might have overexercised, they didn't eat enough, illness such as vomiting, diarrhea, that could also disrupt the amount of sugar that they actually have inside their body. Now on the reverse side of the spectrum, there is hyperglycemia, so that's going to be too much blood sugar. When somebody gets dangerous levels of hyperglycemia, we could also see diabetic ketoacidosis. So diabetic ketoacidosis is a condition that occurs as a result of high blood sugar, and it's characterized by dehydration, an altered mental status, and then also shock. With diabetic ketoacidosis patients, one of the signs that oftentimes we'll see is they have very fruity breath. So it really smells like Fruity Pebbles, the cereal. But here we can see the difference between signs and symptoms from our hypoglycemic patient versus our hyperglycemic patient. Oftentimes for us as EMS providers is that low blood sugar oftentimes is a result of an acute incident. Somebody, in order to get a hyperglycemic state, oftentimes will take an extended period of time. So it's more chronic compared to an acute setting as far as the EMS definition. In order to regulate and ensure proper glucose levels, diabetics oftentimes will have either insulin pumps, and almost all of them will have blood glucose monitors. So insulin pumps, we don't see this a whole heck of a lot, but they are out there. These are implanted insulin pumps. They create insulin infusion directly into the patient's system. So they can actually titrate that dose based on the little remote control that they have attached to their belt. With blood glucose monitors, this measures the sugar levels within the patient's bloodstreams. So for you as EMTs, this is in your scope of practice. Anytime that there is somebody with an altered mental status, whether they have a history of diabetes or not, we should always be making sure that their blood sugar is within that adequate normal value. This is what that insulin pump looks like. So again, it is actually administering insulin in for that patient. Now, if a patient doesn't have an insulin pump, they will take it subcutaneously, or there's different oral medications that they can take in the form of insulin as well. Variety of different glucometers. All of them are basically operate the same. Insert your test strip. That glucometer will be turned on, and then it will ask for a blood supply value. Once you administer that blood supply value into that test strip, it will take a few seconds, and then it will give you your glucose reading. So these are optimal glucose values. Again, when we're diving into our patient assessment tools, we want to be diligent about asking the patient, what is your normal blood glucose value? Some individuals run normally high, others run normally low. Again, you're doing your best patient assessment to really formulate what's going on. As far as treatments go, for that diabetic patient, when it's a known hypoglycemic event and they have an altered mental status, we can administer oral glucose. Remember, for contraindications for this, they have to have an intact gag reflex. They have to be able to follow commands and be able to protect their own airway. It's going to be in the form of a gel. It's going to come as a dosage of 1 tube or 15 grams. Basically what it is, mechanism of action, is it's going to increase that blood sugar value because what you're administering to that patient is basically cake frosting. So in order to administer that, make sure that you remove the top, either hand that to the patient or they can self-administer, or you might actually have to squeeze that gel inside their mouth. Now, diabetes isn't the only cause of altered mental status. However, it is a very common one that we're going to come across. Now, other causes that could potentially cause that altered mental status: sepsis, severe infection, a seizure, stroke, hypoxia, head injury, syncopal episodes, and then also drugs and alcohol can cause that altered mental status. So first, when we're looking at sepsis, sepsis is a system-wide infection, very severe. Signs and symptoms that we can see with sepsis, you can see an altered mental status, increased heart rate, increased respiratory rate, usually a low blood pressure, high sugar levels, and then we could see a decreased capillary refill time too. So what's going on inside the body is, based on the infection, is the cells are losing that permeability, they're leaking fluid, and so our fluid shift inside of our system is off. Other signs that we're going to see oftentimes is a severe fever as well. That's that indication of that infection. So here we can see that bacteria or that virus infecting that system. And again, it's going to lead to that fluid shift with that cell permeability. And then that patient is going to be able to perfuse very adequately. And then also that bacteria or that virus is going to begin to attack different organs and different systems inside the body as well. Seizures. So a seizure is a sudden change in sensation. So this is often characterized by that tonic-clonic movement, where it's that violent jerking and shaking. The tonic phase, this is rigid stiffening. And then the clonic phase is going to be violently jerking. So that's why we refer it as the tonic-clonic when somebody is actively seizing. Now there are different types of seizures where we may or may not see this active movement. Then after the seizure is done, basically that patient's body's got to reset. So this is going to be the postictal phase. So this is going to begin when the convulsions stop. The patient's going to begin to regain consciousness, and most oftentimes they're going to be altered while they start to get more oxygen inside their system. Because the biggest thing with a patient who suffers from a seizure is the fact that they're not adequately protecting their own airway, and as a result, they drop in hypoxia states. Some causes of seizures that we're going to see is hypoxia. So somebody who's got a low oxygen content can lead to that seizure-like activity. A stroke can also cause that, or we have a severe head bleed or severe obstruction inside the blood vessels of the brain. Also a traumatic brain injury, very common, and then toxins, drugs, or alcohol too. So when the fake pot was out there with the last place on earth, that synthetic marijuana caused a lot of individuals to go into a seizure. Also, somebody whose blood sugar gets so low, that can also cause a seizure. Any type of brain tumors or congenital brain defects also will characterize that seizure. And then we talked about sepsis too, where we have that severe infection. Also not listed here too is epilepsy. So some patients actually have predisposition to seizures. So as far as our patient assessment and care, so we never want to stick anything inside the patient's mouth when they're seizing. What we're going to do is let them seize and then protect them the best we can. So maybe place padding underneath the head, remove any furniture that's around in order to get that away from the patient. So we can ask, what was that person doing? Did they have an aura? An aura is something that is a sensation that they might experience before that seizure actually started. So example, somebody might smell, citrus flavor, or taste something, or see bright lights inside their eyes. That's going to be an aura and that's going to be an indication that a seizure is coming on. Next, what did they do when they were seizing? So did they have that full body movement, that tonic-clonic movement, or some patients might have different types of seizures. Big thing too, we want to know how long did it last, and then also did they fall or cause any injury or harm to themselves when they did seize. So what did that person do after that seizure? Remember to protect our patient. Once they are done seizing, then we can go ahead and put them into the recovery position. So kind of place them on their side in the event that they vomit, then you can safely and maintain that patient's airway. Administer oxygen. Again, patients don't breathe adequately when they are actively seizing. So placing that oxygen on that patient is going to help them improve within that O2 stats. Always check that blood sugar and consider ALS, especially if that patient is continuously seizing, because advanced life support can show up and then actually administer medication that will stop them from seizing. So here is our different characteristics of seizures or different types of seizures. As you can see, we have a lot of different ones ranging from our simple partial or absent seizures all the way down to our full tonic-clonic movements. Next, we're going to be looking at stroke. So stroke is going to cause that altered mental status either by an obstruction, so this is going to be referred to as an ischemic stroke, or a head bleed, in which that patient is actively bleeding inside their brain. Another form could be a TIA. So this is a transient ischemic attack, oftentimes referred to as a mini stroke. So with the difference between a full-blown stroke and a TIA is the TIA, those signs and symptoms will go ahead and resolve themselves on their own. And as a result, that patient will be able to regain full consciousness. Signs and symptoms that we're going to see with somebody who's suffering from a stroke or a TIA, you can see confusion, dizziness. Oftentimes, classic signs and symptoms will see facial droop, slurred speech, and then numbness, weakness, or paralysis on one side. Oftentimes, we're going to see hypertension too with these patients. Could also see seizures, headaches, and oftentimes when somebody's describing a headache with stroke-like symptoms, they'll classify it as a sudden onset of that stroke and the worst headache that they've ever experienced. Our assessment findings, what we would see and utilize is a Cincinnati stroke scale. So we're going to have them smile and show their teeth. What we're looking for is any type of facial droop. We're going to do an arm drift. So we're going to have them close their eyes, extend their arms to their full capacity. Then we're going to let go of their hands and see if one of those hands drops at all. We want to be diligent as far as when those signs and symptoms started, because the hospital has only got so much time in order to push certain fibrinolytic drugs in order to resolve that clot. So really getting a good time as far as when those signs and symptoms started. Normal baseline for that patient, because patients oftentimes have multiple strokes, so try and differentiating between a new stroke and then the repercussions of a previous stroke. Always get those vitals. As far as care goes, we can call a stroke alert, get that patient to the proper facility. So both St. Mary's and St. Luke's, they both have cath labs and fibrinolytic therapy capable for treating patients with strokes, and then also providing oxygen therapy. So this is the Act Fast algorithm. This is kind of the community education aspect of EMS. So this is what's taught to the public. And then this is kind of what we're utilizing too for that Cincinnati stroke scale. Next, we're going to talk about a syncopal episode. So syncopal or syncope is just a fancy word of calling it fainting. A couple of different causes that we could see with cardiovascular causes. It could be an MI, electrical changes or dysrhythmia. Hypovolemia causes, this could be from low fluids, so somebody's dehydrated, or they're sick and they're nausea and vomiting, or low blood volume. So are they suffering from a stroke where they have a head bleed or externally or internally bleeding? We could also see metabolic and structural causes, so structures of the brain, also ear infections, where somebody's got a severe ear infection, it can throw off how their brain operates properly. Environmental conditions, so drugs and alcohol can cause that syncopal episode, or somebody who's too hot or too cold. All right, that eliminates our altered mental status lecture and diabetes. So we'll dive into our patient assessments and be working on our poster boards for these different diseases as well. Thanks, everybody.